Good afternoon. My name is Ann Lotierzo. Thank you for taking time to view this presentation. This case presentation has been modified according to American Counseling Association guidelines to preserve the anonymity of the individual client. It focuses on a single case study of a client with application of cognitive processing therapy, but seeks also to highlight the positive and negative influences that contributed to her symptoms and the overall therapeutic process. We are beginning today with a basic agenda to present and review a case summary, walk through the steps of assessment and diagnosis, and arrive at the treatment process. Some basic housekeeping rules for the presentation. First, this presentation plays on its own without need to forward to the next slide. Second, if you'd like to pause or replay a slide, you can do so by hovering at the bottom of the slide. And last, references are listed at the end of this presentation, along with a guide that is attached to help match the reference with the slide. A very wise psychologist once told me, "Everything matters. Get to know every little thing about your clients." So we begin today by getting to know Angela. Angela is a 24-year-old single Hispanic female diagnosed with post-traumatic stress disorder and previously treated intermittently with antidepressants prescribed by her primary care physician. 8 months ago, she began treatment at a community-based agency where a psychiatrist continued medication management and referred her for supplemental therapy services. She notes that the actual referral time was nearly 1 year ago, but due to some hesitation in following up with the referral, her services were delayed. This is consistent with the research that points to barriers in obtaining mental health treatment that include guilt, shame, and hope that the illness will cease on its own. Angela identified strongly with feelings of shame and guilt associated with her symptoms, stating, "I hated myself for asking for help. I felt like everyone would think I was weak. It was embarrassing. So many people have more important needs." It was important to note this statement at the time of the intake because it revealed the underlying roles of shame and guilt, how both influenced the exacerbation of Angela's stressful symptoms, how they functioned as barriers to initiating treatment, and how they may continue to inhibit success in the therapeutic process. Although shame and guilt are related, they remain distinct constructs with different effects on thoughts and behavior. Angela's shame surfaced as a negative self-perception, seeing herself as a failure, revealed in statements like, "I can't find a new job. I dropped out of college. I can't get it together without therapy." Whereas her guilt seemed to surface in relation to using services that someone else may need more, displayed in statements like, "Other people have more important reasons to come to therapy." As will be seen later on, both constructs resurface as major influences on her treatment and in relation to the traumatic events that she experienced in her adolescence. Academically, Angela reports moderate achievements, noting that she enrolled in the local community college after high school, but dropped out during her second semester, citing stress, anxiety, and depression that interfered with her ability to complete assignments successfully and timely. For the past 5 years, she has worked as a waitress and as an aide in a nursing home, earning sufficient income to achieve financial independence, purchase her own car, and share expenses with a roommate in an apartment, until recent financial instability set in. At the time of the initial assessment, Angela reported that she was forced to give up her apartment and move back into her parents' home for financial reasons related to the loss of stable employment. Angela, like many others during the COVID-19 pandemic, was negatively affected by the disruption to the economy and experienced the loss of personal independence from her parents, secondary to the loss of income. It is also noted that Angela experienced a loss of personal significance when her employment ended. She was forced to give up something that she valued and also contributed positively to her self-perception and self-worth. This experience is consistent with findings in the literature that discuss the impact of COVID-19. After losing her opportunities at college, Angela had found meaning and value in her work at the nursing home until changes in staffing patterns ended her employment. Historically, Angela reports one previous involuntary psychiatric admission at age 16 for 7 days. This following evidence of severe depression noted by a school counselor. Her history is noted as significant. Plans to monitor any changes in her status will be accomplished through the use of the Patient Health Questionnaire, the PHQ-9, at each session. The PHQ-9 is recognized as an evidence-based tool for monitoring symptoms associated with severe depression. Angela denies any legal history or substance use history. She does admit to social use of alcohol on occasion. She recalls brief periods of outpatient therapy, but describes them as negative experiences without noting any improvement of symptoms or positive mental health outcomes. Angela also observes that her parents were unsupportive of therapy and quickly permitted her to withdraw without any objections. Angela is the eldest of 6 children in her family of origin and is currently living at home and sharing a bedroom with 2 of her younger sisters who are both high school students. She describes her parents as hard-working migrant farm workers who dedicated their lives to their children and sacrificed for their futures by traveling to the United States of America from Mexico for educational opportunities. She describes strong family ties and support among her siblings, with her parents, and with her extended family, including paternal aunts, several cousins, and her maternal grandparents. She recalls a childhood strong in both Mexican and Catholic tradition, with weekly attendance at Mass, frequent family participation in church events, and describes her faith and spirituality as significant coping mechanisms in her life. This was an important part of the intake assessment to observe, with research providing evidence that demonstrates how religiosity plays a protective role in coping with trauma. Focus on already existing coping mechanisms such as prayer and scripture was important for Angela because it provided her with support in between sessions. However, it was also important to observe at this point that Angela noted an increase in conflicts with her parents regarding adult choices not to attend Mass regularly. She reports both guilt and shame related to feeling like a disappointment to her parents and failing them in this aspect. Angela describes 2 traumatic events in her adolescence, noting that both had a significant impact on her and the surrounding community. Specifically, she describes witnessing a car accident that claimed the lives of 4 teenagers from her church community when she was 14 years old. She recalls that the night of the accident, a group of teenagers, including herself, left the church after an all-day retreat and attended a movie at the local mall cinema. Following the movie, the caravan of cars followed in line on a rain-slicked roadway until the first car in line lost control and veered off into a body of water. Angela experienced severe distress and grief after the event. She recalled the immediate onset of nightmares and flashbacks, while describing, though perhaps not yet understanding, hypervigilance and avoidant behaviors. She reports attending all-night vigils in honor of her deceased friends and frequent prayer services in their memory. She distinctly recalls the onset of anxiety attacks when her family would get into their minivan to travel to these events. Angela's recollection of these anxiety attacks would lead to future insights about her symptoms during the CPT sessions. The second traumatic event occurred when Angela was 15 years old, and she was participating in a youth-focused event at the Hispanic Ministry Center that had recently been opened in the community. As was common, the center hosted weekend retreats and accommodated large groups of teenagers with young adults in attendance providing supervision. Angela recalls the event was centered on All Souls Day, a traditional day of prayer and remembrance for the souls of all those who have died. This day was of particular significance for the community, following the loss of the 4 teenagers and others in the close-knit community. The day began with a festival to raise funds for the center and would end with an all-night vigil. Angela recalls sitting in prayer with some friends and drifting off to sleep for a few minutes before being awakened by shouting and chaos. She opened her eyes to find two masked intruders dressed in Halloween costumes brandishing weapons. The next hour was marked by panic and fear amongst the attendees, who feared for their lives at the hands of the assailants. Angela and the other attendees escaped without any physical harm and were ministered to by an emergency crisis response team that assembled the next day at the church. Angela notes that the assailants were captured within hours of the event and found to be local teenagers who were known to the church community. We paused briefly with the case summary to summarize some of the environmental, cultural, and religious factors that influenced Angela in her life and may become significant during treatment planning and in the overall treatment process. By her report, there are some tangible factors at work that influence her lifestyle, her free time, and perhaps even her perception of the world. It appears that the environment she was raised in valued the role of religion and nurtured her faith in God. Does it appear that Angela looks at her life through a Christian worldview? It may be premature to say, based on the information we have learned thus far, but there are certainly some signs already that should prompt us to look for more. What about the influence of those factors on her treatment? There is sufficient research to support the benefits and efficacy of integrating spiritual beliefs and even practices into counseling. The American Counseling Association's Code of Ethics supports inquiry into a client's spirituality as part of the assessment process. In Angela's case, it appears evident, so the question at hand seems to be not if spirituality would be integrated, but when and how. As we are building a general profile of Angela, it is important to remain attentive to the details that she reveals, both spoken and unspoken. The mental status exam is a valuable tool used by a clinician to gather observations about the client and also form a baseline for future encounters. Many questions are answered in the mental status exam before any are actually asked by the clinician. Is a client performing daily activities like bathing? Does she present as anxious? What is her affect? Is she engaged in the session? Angela is oriented ×4, appears of average weight and height for her age. She was casually and modestly dressed in jeans and a top, displayed evidence of good grooming and hygiene. There are no observable scars, bruises, or tattoos. She wears earrings, a small crucifix necklace, a watch, and a bracelet engraved with the initials of 4 of her deceased friends. Eye contact is sporadic throughout the encounter. She initially appears open and relaxed, though evidences some reluctance and becomes guarded in later parts of the session. She reports her mood as anxious and presents with an affect congruent with anxiety. She is tearful at times, though remains cooperative and engaged with this clinician. Thoughts are logical, coherent, and goal-focused. I want to get on with my life. Speech is clear, soft at times. Cognitive functioning and memory both appear intact, with evidence of average intelligence. There is no evidence nor complaints of auditory, visual, or tactile hallucinations. Angela denies any current or past suicidal or homicidal ideations and denies any history of self-injurious behaviors. The clinician-administered PTSD scale was administered to Angela, with a score in the severe range, meeting diagnostic criteria for PTSD. Criterion A was met, in the instance of both events, by witnessing the car accident and as a victim in the hostage event. For Criterion B, it is noted that she experiences nightmares, flashbacks, and upsetting memories in relation to both events, while meeting Criterion C by describing significant avoidance of any external reminders of the event, including the scene of the crash and other survivors who had previously been her friends. Criterion D is evidenced by the blame she places on herself for not suggesting another route home the night of the accident, as well as a generalized sense of isolation and diminished interest in activities. Criterion E is evidenced by ongoing struggles with concentration, hypervigilance, and difficulty sleeping. She also completed the Beck Depression Inventory and the State Trade Anxiety Inventory, indicating depression and anxiety symptoms in the severe range. With collaboration from her treating psychiatrist, Angela was provided an overview of the results from her assessment. The psychiatrist also spent some additional time providing some more education for her medication. A consent for CPT treatment was provided that included details of the process. Developing a treatment plan began with exploring some options with Angela and briefly consulting with her psychiatrist. It seemed necessary to ensure that the approach must include room for spiritual integration based on her needs and already existing practices that included prayer and reading scripture. Also, Angela expressed a strong desire to integrate her spiritual practices into counseling sessions, and it appeared important to accommodate this. Consideration of CPT was primary in the decision-making process because of the structure, the noted efficacy for PTSD, and the ability to integrate spirituality in the process. The highly structured approach would give Angela a basic goal or timeline to commit to, which seemed important to her and her long-term goals to again pursue college and a career. It was also at this time that consideration was given to some of the identified dropout risk factors identified in the literature as a lack of confidence in the techniques, a belief that changing course or theory in the midst of therapy was not permissible, and of course the practical factors, such as integrating therapy within a weekly routine. Perhaps most important, it is noted in the literature that clients with PTSD are deeply affected by the function of avoidance, which may increase the difficulty in engagement in the psychotherapy process. During the first session, Angela displayed some anxiety and hesitation to move forward. She reported concerns about doing it right and wondered if she would experience feelings that were too sad. She particularly focused on the grief associated with the death of her friends, because coming here reminds me of them. Angela also shared that she was feeling physically tired and had experienced a loss of sleep in recent days because her grandmother was ill. It seemed important at this point to consider if this was a manifestation of resistance, and if so, was she at risk for early termination? Consideration of Angela's current emotional state was primary, and it seemed important to embrace the emotions and review coping mechanisms. Instead of proceeding with the agenda, we paused to address her emotions and explore some of the coping mechanisms she uses to manage them. Her Catholic background provides her with certain traditions and rituals, like the rosary, that were already in place for her as coping mechanisms. It was relevant for Angela to find acceptance and integration of those tools in the therapeutic process right at the beginning. It appeared to validate her personal efforts toward coping, which was essential during these early stages. At this point, Angela witnessed also that she had a role in determining the direction of therapy. This is endorsed in the literature as an important experience, correlated directly to strengthening the therapeutic alliance. Supportive counseling was also provided, and the initial session was postponed until the following week. Angela appeared calm, relaxed, and focused for the initial CPT session. A review of the agenda for the session was explained, identifying target goals to A. Describe the symptoms of PTSD, B. Help provide a framework for her to understand why she struggled with these symptoms, and C. To provide an overview of the treatment, with emphasis on why practice at home and consistent session attendance was very important. Information about PTSD symptoms was provided to Angela, with feedback from her regarding the different types of symptoms she experienced. She focused strongly on the flashbacks from both identified traumatic events in her history and made significant associations between the flashbacks and her hypervigilance when in a car or at a church. She also endorsed nightmares, self-blame, and admitted to a decrease in socialization. Her interest in understanding this collection of emotions, thoughts, and behaviors was noted. Perhaps one of the earliest signs of the benefit of investing in the educational piece for PTSD symptoms was a connection she made on her own. She reflected on a family trip to Mexico and commented how insightful she felt afterwards, stating, I felt like I finally understood why my parents did things the way they did, why they created rules that my other friends didn't have, why we did things all together as a family, why we always went to church. It all started to make sense after that trip. She was equally enthusiastic about understanding the connections between PTSD symptoms and how one may influence the other, stating, "I hope everything can make sense like this." However, this enthusiasm was not sustained over the course of treatment and did wane significantly between the first and second sessions. As the session continued, Angela processed information about the traumatic events, noting that both events were intertwined in her mind. She appeared torn between sadness and anger, noting how so many milestones were passed without her friends present. "We graduated without them. They had their whole lives in front of them. It's just not fair." Significant time was spent on explaining how her perception of the events may have contributed to a change in her belief system, leading to self-blame, with focus on some of her earlier key statements like, "I should have done something to stop these things from happening," and "Why was I in the second car and not the first car?" These thoughts were explored in the session and led to discussion on the way trauma affects beliefs about safety, trust, power, and particularly in Angela's case, her trust in God. At the end of the session, the worksheet for creating her impact statement from the CPT manual was given to Angela, along with additional readings about trauma. During the next sessions, time was spent reviewing Angela's impact statement. When asked to read it aloud, there was some strong resistance before she agreed to try. She did not make it through the entire statement, and it was tabled until she felt ready to try again. The statement reflected a strong association between the causes of the car accident and the power of God. Angela expressed disappointment, anger, and blamed God for failing to intervene in the accident, at times questioning if her friends and herself were good enough in God's eyes, and wishing for another chance to make things right. Angela made connections between her anger toward God and her current attitudes toward church and attending Mass regularly with her family. She identified a few issues as stuck points, including the guilt about surviving the crash and blaming herself for not directing everyone to take a different road home. Because loss and trauma can disrupt the spiritual and religious beliefs already established, some attention on those ideas is needed, with perhaps some modification in order to facilitate successful coping. Discussion in the literature points to reliance on religious teachings and beliefs to help understand trauma, with most people developing either a stronger religious stance or abandoning faith and spirituality altogether. In the case of Angela, however, she appears in conflict, relying on prayer, scripture, and religious images and symbols to help alleviate grief, but avoiding Mass attendance and any formalized engagement with the church community, while also continuing to try to understand God's role in the events. She continued to question the role of God in the car accident and identified this as one of her stuck points. As Angela progressed through the second and third sessions of CPT, there was focus on A, discussing the meaning behind the events, and B, helping her recognize and label thoughts and emotions while making connections between what she is thinking, saying, and feeling. She continued to express feelings of anger associated with both events, lamenting that God did not do more to intervene and change the course of those nights. It is important to note at this point that both events were intertwined for Angela, and it was often difficult to discuss one without the other. However, as therapy progressed, it became clear that the car accident had a more profound impact on her symptoms. It also seemed to strongly influence her perception of the world as a safe place, guided and controlled by God. It appeared that CPT was beginning to challenge and modify her perception of the world, remaining, though, sensitive to her Christian perspective, respectful of her belief system, and importantly, at an appropriate, manageable pace. Further exploration of stuck points directed us to identifying two major areas. One, I should have told everyone to take a different road home that night. And two, God should have done something to save them. The second stuck point proved to be a big challenge for Angela because it revealed to her that she had developed and was harboring some tangible anger toward God. As was mentioned earlier, there was a conflict here for Angela between relying on scripture, prayer, and religious images and symbols for strength, and the blame she directed toward God. Interestingly, it was probably one of the most profound moments of therapy when Angela acknowledged that conflict on her own. Exploring stuck points through the use of Socratic dialogue is one of the techniques endorsed by CPT and proved to be somewhat challenging for Angela. A brief synopsis follows. Angela, you say that you should have told your friends to take a different route home the night of the accident. Yes, there were other ways to go home. I should have picked a different one. Angela, you should have picked a different route home? I understand you were sitting in the back seat of the second car. Were you able to control the route home? I should have. I should have said, let's not go on that road. It's dangerous when it's wet. Angela, had you been on that road before when it was wet? Yes, of course. It was summer. It's Florida. It rains all the time. So how were you supposed to know that night was different than any others? Well, maybe God told me and I didn't listen. That summarizes the flow of the Socratic dialogue technique employed with Angela. It proved to be slow, somewhat tedious initially, but advanced to becoming a natural part of the sessions, and Angela remained engaged and interested in developing insights from this process. Later on, her statement content fluctuated between that self-blame and anger toward God and advanced into incorporating observations from other events in her life, particularly her grandmother's death. When integrated questions began to surface, like, did God let her die? Why didn't he cure her? Maybe it was her time to die? When her grandmother died after a long illness, Angela traveled with her family to Mexico for the burial. We remained in contact via phone very minimally during this break in therapy until her return almost a month later. In retrospect, some of important considerations for the use of CPT in Angela's case seem worthy of discussion in light of the cultural, environmental, and spiritual factors that influenced her. First, the structure of the sessions and the overall framework that included a weekly commitment to sessions draws a close parallel to the faith structure important in her family, evidenced by their weekly Mass attendance. And second, the specific agenda of each session, explained and reviewed in advance, demonstrates a parallel to the structure of the Catholic Mass. An agenda of the specific readings, understanding of the prayers and routine, time for reflection, and even homework after Mass when returning to normal daily life activities and trying to integrate the lessons learned in the homily and spoken through the readings. And third, her spirituality was integrated in direct applications of techniques such as the Socratic dialogue and within sessions as a means of coping with emotions. As a therapeutic approach, CPT relies heavily on the structure with specific use of assignments and techniques to achieve a positive outcome. However, discussion in the literature emphasizes recognizing the role of the therapist as paramount, and perhaps even more important than the technique itself. Is the specific reliance on structure a limitation? Is there room for flexibility and integration of spirituality and client preferences? Further discussion is also warranted on the integration of life stressors that develop naturally in the course of Angela's treatment. The strong focus on resolving the PTSD symptoms was relaxed in order to accommodate The grief over the death of her grandmother, family conflicts in the home, COVID-19 stressors, and other personal relationship issues. Limitations? Perhaps better defined as challenges for the therapist who seeks to maintain a balanced, comprehensive approach to treatment, not losing sight of the original treatment plan, but remaining alert and aware to every little thing that transpires during the course of treatment, and setting the stage appropriately so that whatever comes to mind for the client is welcomed into the session. As therapists, called to genuinely care for clients, we must consider evidence-based approaches and become competent in applying those approaches in therapy. However, we are also guided to remain aware of the critical factors of relationships, alliance, and presence as significant in the overall therapeutic process. This emphasis on therapist effects and the person of the therapist is consistent with biblical emphasis on becoming Christ-like. For whom he did foreknow, he also did predestinate to be conformed to the image of his Son, so that he might be the firstborn among many brethren.